Day 3 of our community pharmacy Creminar. Very excited to have you with us today. Uh, the community pharmacy theme continues with um, Dr. Liz Chiarello, and wanted to say a couple of thanks first to the School of Pharmacy, to the American Institute for the History of Pharmacy, and the Erdang Lab. And I have a couple of housekeeping notes before I introduce our speaker, and those are some reminders. First, make sure that you're using the chat feature or raise hand button to ask questions during our Q&A, and we'll have a Q&A again as we've done over the past few days. Please keep your audio muted during the presentation and then during the Q&A. And also, if you're interested, click the live transcript button to view closed captioning. And if it's your thing to be into social media, please use the hashtag Creminar for the different platforms. I wanted to also alert you to the fact that this webinar is being recorded and may be posted to the web or on social media for later viewing by people who couldn't join us today. And there are several who have reached out and said they wish they could be here in person, but are looking forward to watching after the fact. All participants should be aware that their voice, their video image, questions, and name as entered in Zoom may appear in the recording. So I'm going to stop sharing, and thank you for bearing with me as I went through these reminders. What we're doing is discussing community pharmacy, which has been sometimes called retail pharmacy. It's arguably the most common type of pharmacy that offers the public access to medications and a knowledgeable healthcare provider. A community pharmacy or a drugstore also acts as a healthcare facility that's responsible for the provision of pharmaceutical services. And many, if not all, community pharmacies provide medical goods available with a prescription and those that can be purchased over the counter. Excuse me. Community pharmacists, moreover, are considered to be the most accessible health professionals that are available to the public, as you can go in and get personalized advice with an appointment or even in a walk-on basis. And what we've wanted to do at the American Institute for the History of Pharmacy is place a spotlight on the community context and think more critically around this historiography and the types of analyses um, that have been done and which might be encouraged in the future. We're very lucky today to have with us Dr. Liz Chiarello. She'll be talking on Trojan Horse technologies. She's an associate professor of sociology at St. Louis University. She conducts research at that meeting point of healthcare and law, which is, of course, an intersection that's very fruitful. Her research centers on how law and politics work with cultural forces, with organizational policy to influence and impact decision making, not only in the criminal justice system, but in healthcare as well. So Chiarello's current project centers on the overdose crisis in the United States, which she'll be speaking to us today about. And she examines how fields of healthcare and criminal justice have used shared surveillance technology to address the crisis and how doing so has changed professional work and at times undermined patient care. Her work has been supported by the National Science Foundation, um, its Career Award, and her book, Policing Patients, is been recently released or is forthcoming with Princeton University Press. And further, Dr. Chiarello has been a postdoctoral fellow at Princeton University, as well as a Radcliffe Fellow at Harvard University. And lastly, but just as importantly, some of her public-facing work has appeared in multiple popular media, including op-eds and various podcasts. And I just think it's really great that you took the time to be with us, Dr. Chiarello, and very much looking forward to this presentation. And I'll turn it over to you.
Thank you so much, Lucas, for that very kind introduction. And thank you for inviting me to be here. And thank you to you and Kristen for all the work that you've done organizing this seminar. Let me go ahead and share my screen with you. Okay. All right. So thank you all for being here today. It really is a delight. I have to tell you that pharmacy is really my first love, because when I started doing research early in graduate school, I started studying pharmacists, and I have been fascinated by them ever since. So to give you a little bit of background, I'm a medical sociologist and a socio-legal scholar. So I do research at the intersection of healthcare and law, and I'm particularly interested in understanding how healthcare providers' decisions are informed by their cultural context. So I'm thinking about the organizations that they work in, the political environment in which they practice, and the laws that are designed to guide their practice, and how all of that collectively shapes their decisions. And I'm also interested in how the decisions that healthcare providers make shape patients' access to care. I've spent the last 15 years studying the overdose crisis through a sociological lens and using it as a way to think about how the crisis has blurred boundaries between healthcare and criminal justice. What I like most about a sociological lens, I know many of you probably are not sociologists, but what I like a lot about a sociological lens is its flexibility. So with sociology, you can zoom in to look at a single pharmacist making a decision about a single patient. You can zoom out to see the landscape in which the pharmacist practices. You can swing in an arc to trace the historical events leading up to a critical moment in time. It's at its best a complex, multi-layered storytelling device. And that's what makes a sociological perspective so useful for understanding social problems like the overdose crisis. Sociologists insist on examining problems in context, and understanding problems in relation to one another. And that's why a sociological perspective so nicely complements the work being done in history, public health, and public policy. So today I'm going to share some findings from my forthcoming book, Policing Patients. I'll discuss the contours of the overdose crisis, the cultural stories that we tell ourselves, the context in which social problems like the overdose crisis emerge, how healthcare's response to the crisis has created new obstacles, and what we can do to make things better. I'm primarily going to draw from the book's chapter on pharmacists and show you how placing a law enforcement technology in pharmacy has transformed pharmacy work and undermined the pharmacist-patient relationship. So let's begin by tracing the contours of the crisis. The United States is caught in the throes of a relentless overdose crisis, one that has brought the fields of healthcare and criminal justice into an uneasy relationship. Overdose deaths from opioids, including prescription opioids and heroin, increased more than fivefold between 1999 and 2016. Today, overdose is the leading cause of accidental death in the United States, and there were over 108,000 overdose deaths in 2022. Of those, around 6,400, or about 6%, involved a prescription opioid, and that's come way down from a few years ago. It's about half of 4 years ago. Opioid overdose destroys 136 lives every day. So to put that in perspective, that is like a commercial airline crashing every single day of the year, leaving no survivors. The sharp rise in overdose deaths corresponds with a steady increase in opioid prescribing. So you can see from this chart that prescribing rates in 2012 were 2.5 times higher than they were in 1992. By 2015, the amount of opioids prescribed was enough to keep every American medicated around the clock for 3 weeks straight. It was a lot of drugs. The crisis has crested 3 waves, one driven by prescription opioids, one driven by heroin, and one driven by synthetic, not to be confused with prescription fentanyl. That's the wave we're currently in. We're in the fentanyl wave. The problem we're dealing with is multifaceted. It's often framed as an opioid crisis or an opioid epidemic, but we're really grappling with 2 interrelated crises. an overdose crisis on the one hand and a pain crisis on the other. And at the intersection of those crises lie problems of chronic pain, substance use disorder, and drug diversion, or the sale of prescription drugs through illicit markets. Lawmakers, activists, and families have tried desperately to try to intervene. So they've sued the pharmaceutical companies and their affiliates. They've passed laws creating stricter penalties for trafficking fentanyl. And they've tried to shift towards a kinder, gentler war on drugs that centers treatment over punishment, at least in theory. We can learn a lot about the overdose crisis by thinking about the stories we tell ourselves. Americans love a fairy tale. From the stories read at our bedside, to religious texts, to blockbuster films, to an endless supply of legal dramas, we've been trained to spot good and evil. We all know who the bad guys are in the overdose crisis. In a nutshell, Purdue manipulated regulators and physicians to get patients hooked on OxyContin. And when people started dying with drugs in their system, Purdue ignored the warning signs, pushed their drug even harder, and made billions in the process. OxyContin devastated a nation and made the Sacklers, one of the richest families in America, even richer. Meanwhile, doctors, who have been called drug dealers in white coats, handed out opioids as if they were candy. They prescribed enough opioids to keep every American medicated around the clock for weeks at a time. Pharmacists were also complicit. Tiny pharmacies ordered millions of units of opioids, far more than the patients in their tiny town could possibly use. Chain pharmacies turned a blind eye to the opioids flowing across their pharmacy counters. And in this story that we've told ourselves over and over, it's the drug companies and the doctors, and to a lesser extent the pharmacists, who've received the lion's share of the blame. However, the Nigerian author Chimamanda Ngozi Adichie warns us that there is danger in a single story. The problem, she says, is not so much that a single story is wrong as that it's incomplete. When we tell ourselves incomplete stories, we arrive at incomplete solutions. We've been telling ourselves a single story about the overdose crisis, and in doing so, we've struggled to deal with complexity. We've struggled to recognize that the good guys do bad and the bad guys do good. We're woefully ill-equipped to critique bad systems, to unpack how an ecology of laws, norms, politics, economics, organizations, and relationships affect the decisions that people make. We fail to consider that people do bad things because the systems in which they operate invite bad behavior. If systems are failing us, we can't just look at the so-called bad actors. We have to look at the rules of the game. I don't say any of this. Let me be very clear about this. I got asked about this in another talk I gave recently. I am not saying any of this to let Purdue off of the hook. There is ample evidence that they did the bad things that these stories claim. I say this instead because I want to urge us to think about the bigger picture. And my research is designed to help us do that. I want to do more than create a more detailed picture of the story that we already know. I want to use the overdose crisis to help us think about other similar social problems and the broader context in which they arise. Comparing and contrasting cases is what enables sociologists to build theory across social problems and can help activists urge political leaders to create policy and practice that prevents this kind of tragedy from ever happening again. So let's begin by examining the broader social context in which the contemporary overdose crisis occurred. The overdose crisis is both a devastating tragedy for people whose loved ones are caught in its grip and a constructed social problem shaped by institutional power dynamics that affect how we define and respond to this issue. In other words, the overdose crisis and our approaches to confronting it are distinctly cultural phenomena. Contemporary approaches to the overdose crisis are dominated by two fields, healthcare and criminal justice, that bring very different worldviews, tactics, and resources to bear, and that are independently inadequate to handle a problem of this magnitude. My research examines how these disparate fields tackle the same social problem and how they do it against the backdrop of 4 cultural touchstones. The first touchstone is professional constraints in the US healthcare system, a system in which profit often takes precedence over patient care. Over the last few decades, we've seen the rise of managed care and the rise of big business in healthcare, where physicians and pharmacists make decisions under significant power to perform efficiently. In pharmacy, what that has meant is the decline of independent pharmacies and the rise of the big chain pharmacies. And so we're seeing fewer independent pharmacy owners and more pharmacists who are working for large corporations. The second touchstone is the interplay between organizational fields. So organizational fields are organizations that in the aggregate belong to a specific branch of society. Criminal justice and healthcare are fields, and so are religion, art, education, etc. What holds fields together and distinguishes them from one another are core principles, what sociologists call institutional logics. For example, and this is in a nutshell, criminal justice operates on a logic of punishment, and healthcare operates on a logic of treatment. When faced with social problems, so issues like crime, illness, and poverty, each field brings its own perspective, offers its own solutions, and fights to have its solutions realized. How we treat social problems depends quite a bit on which field gets to decide what kind of problem it is, what logics it uses to frame it, and what solutions it thinks are best. However, not all fields are created equal. Some exert significantly more power than others. Today, one of our most powerful fields is criminal justice. We have a tendency to criminalize all kinds of things. So that brings us to the third touchstone, which is the criminalization of social problems. And there's a history to this. So the United States began to experience what's been called a punitive turn in the late 1970s, which was a time during which the logics of crime and criminality began to overshadow logics of care and rehabilitation. And this happened in many different places. It happened in prisons, it happened with regard to street crime, you name it. We really started to buy into these concerns about crime and criminality and use them to shape how we dealt with social problems. So since that time, we've seen the criminalization of all kinds of things, things from poverty to homelessness, to housing, to HIV/AIDS. All of it has had this kind of criminalized edge to it. There's a reason we have a war on things that are social problems. We have a war on poverty, a war on drugs. Not only do we turn to the criminal justice system to solve problems, but we also turn to tech. So the fourth touchstone is the rise of the digital age, in which unprecedented computing power has made it possible to gather, store, and analyze really mountains of data, and then to deploy algorithms that make data analysis and decision-making easy and automatic. So as a result, we've been allocating many of the decisions that once belonged to human beings to technology. So it's technology that's helping to decide how we allocate resources and how we administer punishment. And it's in this context that healthcare and law enforcement have joined forces to stop the crisis. In the process, the lines between these two social fields have become blurry. It's become popular for communities to adopt what they call an all-hands-on-deck approach that incorporates law enforcement, healthcare, and public health, which always sounds really nice. You've got all these groups working together, they're bringing their resources, they're taking it seriously. But the problem is that they don't always work well together, and we'll see why not in just a minute. There's been a lot of focus on how the criminal justice system has taken over healthcare work. So a few examples are police chiefs who like to say things like addiction is a disease and we can't arrest our way out of this problem, which they usually say to thunderous applause. People are really excited to hear cops say things like that. Many police departments have started carrying naloxone, a drug overdose antidote, which many of you are familiar with. police-assisted recovery initiatives in which police connect patients to treatment have gained traction. So you show up at the police department, you give them your drugs, and they're going to get you into treatment that very day. And then a final example is drug courts, in which a judge decides whether a client has completed treatment, and these have proliferated. However, there has been decidedly less attention to how the healthcare system has taken over criminal justice work. And that's where my research comes in. I study how the implementation of a criminal justice technology in healthcare affects doctors, pharmacists, and patients. So one way that lawmakers have tried to reduce overdose deaths is by implementing prescription drug monitoring programs, or PDMPs. PDMPs are surveillance technologies that track all of the controlled substances in a state. The way they work is they aggregate pharmacy data. So every time a pharmacist dispenses a controlled substance, it goes into the prescription drug monitoring program. And then it gets aggregated at the state level and sometimes across states, depending on whether they belong to this large interstate system. And then that aggregated information is fed back to healthcare providers who can use it to track patients, but it is also fed back to law enforcement who can use it to track providers and patients. So PDMPs are two-tiered surveillance technologies. In the book and the earlier article, I theorized that PDMPs are Trojan horse technologies. So think back to the myth, which may be high school. It certainly is for me. The Trojans were horse people, which is why the Trojan horse was such an appealing gift. They were like, oh yes, this looks just like us. But when they wheeled it behind their walls, they never suspected that inside were Greeks who wanted to kill them. Now, the PDMP works the same way, but without all of the death and destruction. Physicians and pharmacists already use a host of technologies, so adding one more seems reasonable. So for physicians, it's really the electronic health record. The PDMP is quite similar to the electronic health record. But what these providers don't realize is that PDMPs are embedded with enforcement logics that emerge through daily practice. PDMP use reorients healthcare providers toward surveillance and enforcement. Now, the other reason that PDMPs are so appealing is because the enforcement environment surrounding healthcare has grown more treacherous in a variety of ways. So the main law that governs opioids, the Federal Controlled Substances Act, passed in 1970, requires physicians to prescribe in good faith, which means for an established patient for a legitimate medical reason. And then it assigns pharmacists a corresponding responsibility to make sure that the medication is being used for a medical purpose. In the past, it was really difficult for law enforcement to assess healthcare practice. They were the ones in charge, but they struggled to do it. And that's not true anymore. In 2006, the Drug Enforcement Administration created what are called tactical diversion squads that focus specifically on healthcare crimes. And the PDMP gives enforcement agents access to fine-grained information about prescribing and dispensing. The other big change is that in 2016, the Centers for Disease Control and Prevention established a set of guidelines for treating pain, including a recommendation to keep patients at or below 90 milligram morphine equivalents, which for many people that's a huge dip. If you get tapered down from 300 milligram morphine equivalents to 90 milligram morphine equivalents, that's a pretty significant change, and people really struggle with that kind of tapering. So these were guidelines, but these guidelines were almost immediately treated as if they were law by healthcare leaders, insurance companies, and lawmakers. All right, so this is the cultural, legal, and technological environment in which physicians and pharmacists practice today. They have been blamed for the worst drug crisis in US history. They have a law enforcement surveillance tool at their disposal. Law enforcement has gotten better at watching their every move, and the CDC has issued guidelines that have been interpreted as law. So I was really interested in how this broader context shaped how healthcare providers made decisions about opioid provision. So I spent the decade between 2009 and 2019 interviewing 337 physicians, pharmacists, and enforcement agents about how they were dealing with the crisis. The goal was to create what I call a nested maximum variation sample, which means I wanted the largest possible degree of variation across different legal environments within each profession. So a lot of times people do more a different kind of sampling strategy where they're looking for the average experience and you're trying to find, the average pharmacist and aggregate that. That's not what I'm doing here. I was trying to take people in all different areas of the healthcare system and the criminal legal system and see what they were grappling with. So I'm not looking to generalize statistically from these data. I'm looking to generalize theoretically, which we can talk about more in Q&A. All right, so I selected 3 states based on the different locations of the PDMP. I thought, the group that controls the PDMP might shape what kind of tool it is. So I looked at California, where it's in the Department of Justice, Florida, where it's in the Board of Health, and then I chose Missouri as the negative case because at the time, Missouri was the lone holdout. It did not have a prescription drug monitoring program. They have since adopted one, first at the county level and now at the state level, but it's in the Department of Public Health. So I still have this maximum variation sampling strategy. Within each state, I interviewed 3 types of physicians, primary care providers, internists in family medicine, pain specialists, and emergency medicine doctors. 2 types of pharmacists, chain and independent. I had talked to hospital pharmacists for an earlier study. I didn't talk to them for this study, but if they were an outpatient hospital pharmacist, they are included in this data. And then I also talked to all kinds of enforcement agents. So everyone from local police to the DEA, federal and state fraud investigators, investigators for the Board of Pharmacy and the Board of Medicine, prosecutors and defense attorneys, members of local narcotics task forces, you name them, I've talked to them. So today I'm going to focus on the pharmacy data, which consists of cross-sectional and longitudinal interviews with 170 pharmacists in 8 states. We can talk about those other states if you'd like, but these are kind of the core states. I learned that one of the biggest challenges that pharmacists face is deciding which patients are deserving or undeserving of care. Now, I should be clear that pharmacists don't usually talk in the term deservingness, that sociological language that I'm using to make sense of their decision-making. But I use that to show that there is a moral valence to the decisions that pharmacists are making. There are 3 types of patients who might come looking for opioids: patients in pain, patients with a substance use disorder, or patients who are diverting or selling their medications. And of course, the same patient can belong to multiple groups. Now, legally, pain patients are the only patients that pharmacists can dispense opioids. And they have a really hard time figuring out who those patients are. They also have limited time to make that decision. So pharmacists are caught in a dilemma. Their employers urge them to be as efficient as possible. Meanwhile, law enforcement urges pharmacists to be cautious. Pharmacists who don't fulfill their corresponding responsibility under the Controlled Substances Act risk legal trouble, but pharmacists who don't go fast enough can find themselves in hot water with their employers. So they're really stuck. As you probably already concluded, or you might know firsthand, it's really difficult to be cautious and efficient at the same time. And that was true for pharmacists until the PDMP came along. The PDMP enabled pharmacists to please their employer and avoid law enforcement, which is a large part of what made that technology so appealing. However, as you'll see, the benefits of this technology came at a cost. PDMP use has changed pharmacists' behavior in ways that blur the boundaries between healthcare and criminal justice. It operates as a Trojan horse technology that ushers enforcement logics into healthcare work and detracts pharmacists' attention away from patient care. So I'm going to show you how this works through 4 mechanisms: changes in pharmacists' routines, relationships, and roles that motivate them to route patients out of the healthcare system and into harm's way. Pharmacists' choices about whether to dispense opioids depend on how they categorize patients, which is a process that sociologists call social sorting. Pharmacists sort patients by asking, what kind of patient is this? Is this a patient who's in pain, has an opioid use disorder, wants to sell drugs, or some combination of the three? Deserving patients have physical pain. Undeserving patients do not. Again, that's not moral valence I'm putting on it. That's how it's woven into the law. So pharmacists have to figure out who they're dealing with and act accordingly. Pharmacists use red flags, things like appearance and behavior, to determine whether or not to dispense opioids. When they identify red flags, they often opt out of dispensing. However, when they have no PDMP, when they have the PDMP, it changes how they say no to the patient. So before the PDMP came along, pharmacists took themselves out of the equation by saying that the drug was out of stock. That was really common. From the patient's perspective, of course, an out-of-stock drug is one that the pharmacist can't provide. It's not one that they won't. And of course, patients are not leaping behind the pharmacy counter to see exactly what pharmacists have on their shelves. Pharmacists are far more assertive when they're armed with a PDMP report. Laura, a California chain pharmacist who I interviewed in 2013, explains how she used the PDMP data to confront the patient. She said before it was more like, I'm not comfortable. Well, why aren't you comfortable? And now we're like, well, because you went to 2 other doctors and you filled it at this independent pharmacy and you filled it at this other retail pharmacy. And then I'll be like, within 30 days, you filled 480 tablets. That's a little too much. And so now they're like, okay. However, sharing PDMP information does more than simply reflect patients' drug acquisition patterns back to them. It also signals to patients that the pharmacist is monitoring them, that they know how many drugs they have been getting, and it can be a means of deterring patients who are getting drugs for non-medical purposes. Pharmacists feel more confident in their decisions when they use the PDMP. So information found there either confirms or refutes the pharmacist's initial impression or their gut feeling, so they can dispense or refuse with a clear conscience. Still, sometimes pharmacists are not so sure. They come across prescriptions that may or may not be legitimate, and they can't get enough information from the PDMP. In those cases, they protect themselves from law enforcement by closely documenting interactions with patients and physicians, which is a practice that I call defensive pharmacy. It's the same kind of thing as defensive medicine. The goal is to protect the healthcare provider, even if it undermines patient care. Pharmacists practice defensive pharmacy when they document interactions with physicians and patients as if they're gathering evidence for an investigation. At the extreme end of documentation, pharmacists require considerable information from patients and closely track any dispensing exemptions made on their behalf. So, for example, if a patient wants an early prescription because they're traveling, Diego, who staffs an independent pharmacy near Miami, requires the patient to show him travel tickets or hotel reservations, and then he copies those and keeps those copies in the patient's chart before dispensing the medication, just in case he gets audited. Eduardo, another Florida pharmacist, keeps track of conversations that he has with physicians to protect himself from the DEA. He told me, if we get audited, the DEA comes in, or God forbid, the patient goes and overdoses, I have that documented conversation. PDMPs also help pharmacists to reimagine and reconstitute relationships with one another and with law enforcement. Pharmacists are positioned in a hierarchy in which physicians exercise significantly more formal power. However, the Controlled Substances Act requires pharmacists to make sure that physicians are prescribing appropriately. That can be a really tricky obligation to fulfill because pharmacists don't normally have access to information like the diagnosis and the treatment plan. Prior to the PDMP, pharmacists often encountered resistance when they called physicians to discuss a prescription. So Jim, a chain pharmacist in Northern California, sighed as he told me, whenever I have to talk to a doctor about medication, they generally don't want to listen. Sometimes they say, I'm the doctor, you're the pharmacist, do whatever I say. Organizational policies requiring PDMP use help pharmacists to counteract resistance when calling physicians. So Tracy describes how this has changed her interactions. When my chain implemented this checklist, she had to call the doctor and ask all of these questions and check them off a checklist. The physicians weren't happy. They were like, what is this? I've never seen this. Why are you asking me so many questions? And basically, we're just like, well, we need to make sure that the patients are, well, not legitimate. We don't use that word, but that they're under the correct care. So just, we need everything to be documented now. So now they're kind of used to it, but yeah, they were pretty hostile. Pharmacists circumvent traditional power dynamics by using their store policy to justify their need for patient information, while at the same time sending physicians subtle messages that they're being monitored and that their prescribing practices might be a problem. Beyond resituating relationships between healthcare providers, PDMP use also helps to create closer alliances between providers and enforcement agents. Prior to the PDMP, pharmacists were pretty adamant that drug monitoring was not part of their job. It always was. I mean, it's in the Controlled Substances Act, but they really didn't see that as a core part of the work they were supposed to do. So one pharmacist, Sarah, stipulated that she was not in the police business. Even when pharmacists did try to ally with law enforcement, they often had little to go on. They had like a gut feeling and a red flag or two, which was not enough to motivate law enforcement to take action. And those who called the police either found themselves in a dead end, or they found themselves like going to court, spending a lot of time, and then nothing ever happened to the patient. And then they felt like they were going to get targeted. So it was kind of a no-win situation. With the advent of the PDMPs, however, pharmacists conceive of their relationship with law enforcement much more positively. So Min, who's a Kansas City pharmacist, collaborates with law enforcement. He once helped catch someone who had written a fraudulent prescription. This is him. He said, we called the police. They said, okay, tell us exactly when she's going to fill it and when she's going to pick it up. And so he put candy instead of opioids in the pill bottle. When she came up to the window, the cops were right there. We get calls all the time from the police. Hey, can you find out if this patient is actually on this? Likewise, Min will call the police if he ever needs assistance. He says, especially with someone who's jumping from pharmacy to pharmacy or doing something that's illegal. The cops will come back to me as well saying, hey, can you check the fill dates for this guy? Or can you check where he's been filling? They kind of use me as a PDMP resource. Meaning that the local police who don't have access to the PDMP ask him to share the information and he complies. And I want you to just take a minute and think about pharmacists doing that for any other kind of medication. You know, the cops calling to find out if somebody's taking their blood pressure medication, or to find out if somebody's taking their diabetes medication. Like, it just wouldn't happen, which speaks to the ways in which addiction as a condition is incompletely medicalized. It kind of sits on the cusp of what we think of as sickness and badness. And we can talk a little bit more about that too. All right, so law enforcement agents also really love this collaboration with pharmacists. In fact, they consider pharmacists some of their best sources for investigating providers and patients. So Joe, who's a California sheriff's deputy, told me, we usually get our tips from pharmacies when it comes to a patient-doctor shopping. We arrested a lady recently who went to 126 physicians in 1 year and got over 10,000 allotted pills. The pharmacist said, hey, I ran a cures report, that's California's PDMP, and she came here to fill the script. It's out of control. You're going to need to look at her. So we did, and we arrested her for doctor shopping. This suggests that pharmacists are not only gatekeepers to healthcare resources, but they're also gatekeepers to the criminal justice system, responsible for moving patients along what Michelle Smirnova calls the treatment to prison pipeline. PDMP use has done more than change how pharmacists make decisions and how they interact with other professionals. It has shifted the very core of pharmacy. Pharmacists are at once asked to be medical and legal gatekeepers. They're supposed to treat patients using the best techniques available, and they're supposed to closely monitor patients for signs of illegal activity. So at one time, pharmacists found these roles incompatible. They hesitated to police patients. It was exhausting, time-consuming, and emotionally taxing. Besides, they were healthcare providers, not police officers. Now they regularly police patients and consider it part of their job. When I interviewed Sarah in 2009, before she had the PDMP, she stated unequivocally, "I'm not in the police business. That's the least fun part of my job, is feeling like you're a police." Like many pharmacists at the time, Sarah clearly defined policing patients as outside of her professional purview. Once pharmacists got the PDMPs, they embraced legal gatekeeping, but not immediately. Policing patients routinely and systematically left them distraught. They began to occupy an intermediate space with 1 foot in medical gatekeeping and 1 foot in legal gatekeeping. Torn between these two roles, pharmacists were uncomfortable. They didn't think that an enforcement tool belonged in healthcare practice. One pharmacist told me that the PDMP is, quote, not healthcare, but rather enforcement of the law. So pharmacists, they were experiencing a lot of dissonance, and they needed a way to reconcile these new routines that monitoring programs made possible with their roles as healthcare providers, the things that they had sworn to do in their white coat ceremony and that their ethics told them that they should be doing. This stressful experience of being pulled in two directions at once soon gave way to a new, largely subconscious reframe and embrace strategy that allowed them to harmonize competing roles. In the end, pharmacists reframed legal gatekeeping as medical gatekeeping to justify their involvement. So they don't see them as two separate roles anymore. They see them as the same thing. In my conversations with Min and Charlotte, who are both chain pharmacists in St. Louis, I remarked that checking the PDMP seemed time-consuming. I acknowledged that, and they said, yes, it does slow them down, but then they thought it was worth it. According to Charlotte, pharmacists like the PDMP because it helps us fill that prescription legitimately and determine if it's an appropriate prescription for that specific patient. She believes that the monitoring program helps her fulfill her ethical obligations. A pharmacist took an oath to do no harm, just like other medical professionals. So it helps us prevent causing harm. Pharmacists' adoption of enforcement activities paired with fortified relationships between pharmacists and enforcement agents raise questions about what these changes mean for healthcare provision and healthcare access. To understand these implications, we turn to a fourth process, routing. Pharmacists constantly encounter patients struggling with pain and substance use disorders. Yet they've received new tools to surveil and punish, but not treat those under their care. Pharmacists respond to this treatment-poor and enforcement-rich environment by using the PDMP to route patients out of the healthcare system and into the criminal justice system. So there are two types of routing. There's direct routing and indirect routing. Direct routing is when pharmacists contact law enforcement about a patient. So an example is the one that I gave you with Min, and he was putting the candy in the pill bottles. That's actually relatively rare. Far more common is indirect routing. When pharmacists refuse to dispense regulated prescription drugs, they expose patients who are physically dependent on those drugs to dangerous, unregulated, illicit markets that carry a far higher likelihood of injury and overdose. Now, please know, I am not blaming pharmacists for people's substance use disorders. It's not their fault. But the problem is that when people are seeking help, when people are going to the healthcare system and asking for help, pushing patients out of the healthcare system not only nudges them towards riskier markets, but it also sacrifices an opportunity to help a sick patient. So this isn't really the way that we think healthcare should work. PDMPs have been touted as healthcare tools, as ways for providers to identify and correct risky patient behavior, but they're rarely used that way in practice. Instead, pharmacists generally use PDMPs to justify refusing to provide care. Pharmacists use PDMPs to indirectly route patients out of the healthcare system where they end up in the criminal justice system. Prior to the PDMP, pharmacists made decisions based on their interpretation of patients' behavior and social cues. Today, pharmacists trust the PDMP to accurately depict patient behavior, so they use the PDMP data to refuse to dispense. Instead of routing patients suffering from pain and/or addiction into the healthcare system, which providers really are ill-equipped to do, pharmacists relinquish them to unregulated markets, thereby increasing the likelihood of patient harm. and entanglement with the criminal justice system. This results in an exacerbated form of cumulative inequality that carries across healthcare and criminal justice, and it has different consequences depending on the patient's social position. It's well documented that race, class, and gender discrimination limits access to pain medication and addiction treatment, and that these same forms of discrimination shape the likelihood of arrest for drug crimes, acceptance into diversionary programs like drug courts, length of sentencing, and post-incarceration life chances. There are significant racial and socioeconomic factors undergirding the opioid crisis, and poor people and people of color are taking the brunt of pharmacists' actions. Of course, pharmacists are trapped in their own bind. They want to help patients, but they don't have the right tools for the job. In many ways, the opioid crisis has turned professional worlds upside down, which raises questions about who we want our healthcare providers to be. If they attempt to embody both punitive and healing roles, how might their enforcement requirements impede their fiduciary obligations to patients? Pharmacists have learned a lot about opioids in the last decade, and they are genuinely concerned about doing more harm than good. However, the tools available to them push them towards enforcement. Like the mythic Trojan horse that distracted the horse-loving Trojans with its shape, enforcement tools have the same contours as healthcare tools. However, these tools also have a pernicious quality that becomes evident when we see patients policed out of treatment and shuffled between practitioners. Forced to straddle the line between treatment and enforcement, pharmacists police patients and call it care. The terrible irony is that there is no evidence to suggest that cutting down on the availability of prescription opioids will reduce overdose deaths. In fact, abandoning patients is likely to result in more deaths rather than fewer. Prescribing rates have been going down since 2012, even as overdose rates have been skyrocketing. And that's because cutting down the legal drug supply has steered people towards the illegal drug supply that is teeming with deadlier drugs like fentanyl and increasingly xylazine. It's a really, really toxic drug supply. Fentanyl contributed to 66% of overdose deaths in 2021. Prescription opioids only 16%. Beyond that, some subset of pain patients have taken their own lives when the chronic pain became unbearable. This is Doug Hale, who was first prescribed opioids in 2001 when he had some bladder inflammation due to a surgery. He tried all kinds of interventions, but opioids were the only thing that worked. His pain was well managed until his primary care physician decided to taper him and gave him 1 month to get completely off of opioids. So by all measures, that's an extremely fast taper. He tried detox, which didn't work. And then when he returned to his doctor asking for opioids, his doctor said, "I'm not going to risk my license for you." The next day, he shot himself in the backyard. In the note he left for his wife, he said, "I can't take the chronic pain anymore." He was 53 years old. So stories like Doug's bring into sharp focus the real human cost of anti-opioid policy. The 4 processes that I've described here, changes in routines, relationships, roles, and routing, are part of the mechanism by which social problems transform social fields and by which the overdose crisis is blurring boundaries between healthcare and criminal justice. Surveillance technology exacerbates the criminalization process. As our world becomes increasingly digitized, and as big data surveillance technologies become taken for granted aspects of everyday experience, surveillance facilitates enormous potential for social control and inequality. Sociologist Sarah Brain has demonstrated that the growing links between criminal justice and other social fields have resulted in what she calls system avoidance. So that is, they've motivated people to avoid social spaces like hospitals, libraries, and welfare offices out of fear of arrest. And this has devastating consequences for the urban poor who already suffer from severe social inequities. This case also raises questions about other arenas in which pharmacists either are or will be asked to police patients. A few are certainly on the horizon. In the past 3 years, we have seen legislators take an active interest in abortion and reproductive health, transgender healthcare, and infertility treatment. Their efforts to reshape whether and how these types of care can occur create significant risk for healthcare providers who face criminal consequences in an uncertain enforcement environment. Healthcare is notoriously risk averse, and providers try to practice well within the legal bounds of care. However, research shows that preemptively shrinking their scope of practice can leave patients without access to legally permissible care. Fundamentally, the question we're left with is who should make decisions about care and how. I'll give you a brief example to show you how fickle lawmakers can be. I conducted an earlier study about how pharmacists make decisions about providing emergency contraception. So at the time, there was a handful of very vocal pharmacists who refused to dispense emergency contraception because they believed that it was an abortifacient. And both conservative lawmakers and anti-abortion activists argued that pharmacists should be able to use their conscience to make healthcare decisions because other providers could, doctors and nurses had conscience clauses, and because pharmacists are professionals, not automatons. So they should enjoy the discretion that other professionals had. Now, you can understand why pharmacists appreciated this position regardless of their political beliefs. And why they were far more hostile to the pro-choice position, which said that pharmacists had no place in the doctor-patient relationship. So this was the early 2000s. Fast forward to 2022. COVID is in full swing, and some physicians and lawmakers think that patients should take hydroxychloroquine and ivermectin, which have no clinically proven effectiveness at treating COVID and could harm patients. Suddenly, conservative lawmakers are thinking about pharmacists really differently. Suddenly, they think that pharmacists should get out of the doctor-patient relationship. My home state of Missouri passed a law that forbids pharmacists from questioning the physician or the patient and prevents professional boards from disciplining providers who prescribe or dispense these drugs. So lawmakers will try to have it both ways. But we can't let healthcare access depend on the way the legislative winds are blowing. That's why we have healthcare providers who are trained to provide high quality care while acting in the best interest of the patient. Sacrificing professional autonomy and discretion to either lawmakers via legislative posturing or to law enforcement via Trojan Horse technology undermines the core of pharmacy practice and puts patients in danger. My research shows that law enforcement has moved more deeply into healthcare. Doctors and pharmacists are acting like cops, and patients have nowhere to turn. Despite all of this, we're still losing over 100,000 of our loved ones every year. It's critical to remind ourselves that what lies at the root of the overdose crisis is human suffering, and that success is measured in how much we help those who are hurting. I think that we can all agree that allowing corporations to profit from harm for decades and then trying to claw back those ill-gotten gains is terrible public health policy. It did not work for tobacco, and it won't work for opioids. I say that because we too often try to address social problems in isolation without addressing related problems or getting to the root of the problem. This siloed approach has not served us. We're not going to get out of this crisis by turning healthcare providers into cops. Blurring the boundaries between healthcare and law enforcement changes the very nature of healthcare work and puts patients like Doug at risk. So where do we go from here? We need better solutions. And finding them starts with telling ourselves a better story, one that goes beyond the bad pharmaceutical companies and the doctors and pharmacists who enabled them. We have to tell ourselves a story that accounts for the broad social factors that shaped this crisis, from social decline to diminishing professional power, to the rampant criminalization of social problems, to the rise of the digital age. We have to consider the needs of people in pain and people with substance use disorders who have been pitted against each other in a zero-sum fight over opioids. And we have to develop solutions that incorporate harm reduction, treatment, and prevention. So to that end, I'll conclude by offering a few concrete actions that we can take. First, we should set boundaries around how PDMP data is used. There is a wide array of stakeholders who see the potential utility and profitability of PDMP data. Once created, a database like this takes on a life of its own. So we need to put safeguards in place to protect patient privacy and limit the commodification of these systems. PDMPs are not going away. The most we can hope for is to channel them towards positive uses. Second, we need to expand treatment capacity by equipping healthcare providers with treatment tools. Our healthcare providers are drowning in the daily challenges of the overdose crisis, and the only life preserver we've thrown them is a criminal justice surveillance tool. We can do better than that. Pharmacists are our most accessible but most underutilized healthcare providers. They are well positioned to expand access to addiction treatment. Research shows that two medications, buprenorphine and methadone, are the most effective for treating opioid use disorder. However, less than half of US pharmacies carry buprenorphine, and then methadone for addiction treatment is currently only available from opioid treatment programs that are separate from the mainstream healthcare system. People have to go every single day to pick up their methadone. Both of these medications should be more readily available, and there's a growing movement to provide methadone in pharmacies, which is a strategy that's worked well in other countries. These efforts have been supported by Nora Volkov, the director of the National Institute on Drug Abuse, and Timothy Fensky, the former president of the National Association of Boards of Pharmacy. But pharmacists can go even further than carrying these life-saving medications. Pilot studies have shown that pharmacists can effectively provide buprenorphine through collaborative practices with physicians. And there's a lot of enthusiasm nationwide about expanding these kinds of partnerships. Third, we need to invest heavily in harm reduction. One of the best things to come out of the overdose crisis, if we can say anything good came out of this crisis, is a stronger, more organized harm reduction movement. The harm reduction philosophy is simple. Meet people where they're at and encourage any positive change. This approach cuts against the grain of pervasive ideas about treatment and recovery, things like tough love and hitting rock bottom. In reality, people don't fail to recover because of lack of will. They fail because effective treatment is not available and drugs are. Punishing people into getting better has never worked. Harm reductionists reject hateful ideas about people who use drugs and advocate instead for radical empathy. Harm reduction includes resources like naloxone, drug testing strips to check for fentanyl, syringe services programs, and overdose prevention sites. These can be critical for keeping people alive, preventing the spread of infectious disease, and linking people to care. Finally, we need to target the psychosocial and economic factors that cause drug crises. I call this capital P prevention. Medicine and criminal justice are vast fields, but they offer blunt tools for addressing social problems like homelessness, unemployment and underemployment, educational inequality, domestic violence, food insecurity, and hypersurveillance that give rise to drug crises. Only by expanding our social safety net and ensuring care for all people can we hope to disrupt the cycle of overdose and death. Prevention means taking the steps necessary to make our communities impervious to those who seek to do them harm. And that means we have to fortify our social safety net by making sure that people have access to education, jobs, housing, healthcare, and mental health support that they need to thrive. And when people fall, and they inevitably will, we must have the treatment and harm reduction infrastructure in place to catch them. That is how we save ourselves. Thank you for your attention. And thank you to the National Science Foundation Career Award Program in Sociology and Law and Science, the Harvard Radcliffe Institute, and the St. Louis University Office of the Vice President for Research, as well as all of my undergraduate research assistants, without whom this work would not be possible. If you would like to learn more, my book, Policing Patients, comes out with Princeton University Press in September, and this QR code will take you to the link.